Today, I had the extraordinary honor of interviewing Dr. Rita Sharon, a pioneer whose work has transformed the way we think about medicine, storytelling, and human connection. Dr. Sharon is the Bernard Schoenberg Professor of Social Medicine and the founding chair of the Department of Medical Humanities and Ethics at Columbia University. She's also the executive director of Columbia's groundbreaking narrative medicine program, which she originated. With an MD from Harvard University and a PhD in English from Columbia University, Dr. Sharon bridges the worlds of science and literature in a way that few others can. Her research and teaching focus on how stories, those of illness, healing, and identity, can deepen empathy and improve care in clinical practice. In this conversation, we explore her journey, her philosophy, and the profound impact of narrative medicine. Please enjoy my interview with Dr. Rita Sharon.
Well, I hear from a lot of high school students.
Mm-hmm.
Most of the work I've been doing is directed to doctors, nurses, social workers, medical students. And then in the past, I think maybe just year or so, I'm hearing from high school students.
Wow.
And they're saying, now how can I get in touch? How can I do this with you? And they've read books I've written and they've, followed things. And it floors me
Yeah.
because this is kind of brand new.
Yeah, it
A kind
definitely
of
is.
agency.
Kind of is, yeah.
And you know what is most remarkable to me is this is at the same time that we hear laments that our young kids are addicted to social media and that's all they do is 8 hours a day with their smartphones.
Yeah.
This is the kind of impression.
I know, yeah.
And when I talk to my friends who are child psychiatrists, they tell me how many of their young patients come to see them and they've already been diagnosed with 7 or 8 different psychiatric diseases.
Wow.
So and I'm sure I'm not the only one, um, the impression that we get, like from, the newspaper and the nightly news,
Yeah.
is that these kids who were born or grew up during COVID and were home, couldn't go to school, that there's something kind of weird about them.
Yeah, I think that impression is very prominent in especially this generation.
Yes. Now, which one do you belong to? XYZ?
Z.
No, but even that, you know, like, oh, she's Z, she must be, and that's
Definitely.
terrible.
Definitely. I 100% agree.
It's like pigeonholing.
I think it's because, especially in this generation where so many technological advancements have been recognized, and more now, even in school, most assignments back in the day were on paper and you had to use pencils, which
Yes,
is very, now, in a sense, it's old school to us.
yes, yes, yes.
But nowadays, we have to take a picture of our homework and submit it to an
Yeah.
online application.
No.
And it essentially we're moving forward in a sense, but we're also moving backward at the same
Yeah.
time. We're moving away from these ideals that have worked so well for generations now. Only
Hmm.
these advancements have only come now. These
Yeah.
weren't existent before. And life moved on as it has. And like you said, psychiatrists are probably finding more and more problems these days because of these technological advancements.
Because even in medical school, there's a push toward what is euphemistically called asynchronous learning,
Hmm.
where the teacher makes a textual or video or production thing, asks the students all to watch it, at their leisure, answer some questions,
Hmm.
do some kind of something, homework, some response,
Yeah.
and like you say, put it back on the portal.
Put it back on the board. Yeah, that's how it
And
works.
then the teacher comes in and looks at the portal, and they can go through a whole semester like that.
Definitely, yeah.
Um, in fact, we teach a narrative medicine, very high level graduate course,
Hmm.
totally asynchronous. Um, we see the students one weekend out of the year.
Wow.
Now, these are international students. So
Ah,
somebody from Korea and from Australia
okay, okay,
and stuff like that.
okay.
And when they get together, oh my God, it's like 2.5 days. They come to the Columbia University campus. We all go and meet with them in person.
Oh,
And because they've been watching me give these like video lectures.
right, right,
Say,
yeah.
oh, that's
And they're
you.
like,
That's really
wow,
you.
yeah. Oh my gosh, that's incredible. Could you tell us a little bit about your personal journey and how you kind of moved from studying literature to practicing medicine? Like, how was that transition?
It was not sudden. I was always kind of both.
Yeah,
I read my way through grammar school and high school. I
hmm.
always had 10 books from the library.
Right, right.
We're all like that. And by the time I got to college, I'm old. So I started college during the Vietnam War. And as soon as I got to college and I came to New York City for college, I grew up in Rhode Island.
Wow.
As soon as I got to New York, I said, oh, there's work to be done here. And I was like immediately radicalized.
Right.
And we would go to the draft board early in the morning and tell the people, the men at the time who'd been
Oh,
drafted, you don't have to come. There are ways to get out of being drafted. You might be a conscientious objector. You might want to go to Canada. There are things you can do. So it was like activism right from the start.
wow. You
And
lived through that.
yeah,
It's amazing.
yeah. And even the college I was at, it was a Catholic university in New York. Even there, it was very progressive. Um, and I had the great fortune of applying and getting into an experimental college where they said, we know that people don't learn by sitting in classrooms.
Hmm.
So it was very small. There were, I think, 15 of us at the beginning,
Wow.
and we all lived in the same apartment building, and
Oh,
our faculty lived with us in that apartment building. It was very communal.
wow.
Um, There was one course that was required of everyone, and each one of the students and the faculty would gather in the biggest room. Um, we had to learn Urdu.
Mm.
The
The
language.
language, right, the language.
We had to learn how to read and write Urdu,
Wow.
and we did.
Oh my goodness.
And the reason they did that is they chose somebody that no one knew how to do. So everybody started as complete beginners.
Complete beginners. That's
Yeah.
amazing.
So that's kind of how I grew up. It was a great departure
Mm.
from your ordinary, you go to college and you take calculus and then you take, you know, biochemistry. Because
Right, right.
I was initially a pre-med.
Ah.
But I decided after all of this activism work, I said, I don't want to be an elite professional because there's work to be done. So
Mm.
it was years and years, and I taught primary school and I did a lot of different things.
That's
And it
incredible.
was years and years later that I said, maybe the idea of going to medical school was a good idea because I was getting a little bored.
Yeah.
So then I
Incredible.
applied to medical schools. I got in at Harvard.
Yeah.
So I went and got my, all the medical training, and I think this is a good thing for students to hear. It was really fortunate that I had been out in the world doing things for a while. I didn't go straight from college to medical school.
Hmm.
I was a school bus driver for several years. I mean, that kind of thing.
Wow.
You
Amazing.
see? You see? So the living takes turns with the schooling.
Yeah,
And
definitely.
and it allowed me, even once I was in medicine, to
Hmm.
not give up my reading and my interest in politics and my
Yeah.
that I brought it all with me.
That's amazing.
Yeah,
It's amazing how you were exposed to both fields. I mean,
that's right.
it's hard nowadays to focus on two things at the same time because of societal expectations or peer pressure and whatnot. Actually,
Oh
what
yeah.
inspired you to combine these two fields that at
Well,
first glance seem so different?
because I could see what was missing in the
Mm,
kind of medicine that we practiced.
mm,
What was missing was the skill and the intention and the devotion to listen and hear and take in the significance of what patients and families said.
wow.
And it wasn't enough to
Right.
know, when does your knee hurt?
Hmm.
And other doctors say, "Oh, I don't have time for that chit chat." If they want to do that, I send them to the social worker.
Yeah.
And I completely disagreed and said, it's what you're calling chit chat is the story of a life.
Wow.
And if you don't comprehend that, if you don't absorb it, what are you, a car mechanic?
Yeah. That's beautiful.
And by now, it's pretty widely accepted. We even have names for it, the social determinants of health. Have you heard that?
Yeah, I've heard of it. Yes.
So what that means is not all illness is caused only by germs or accidents
Hmm. Right.
or cancers that develop.
Hmm.
There are social determinants. So being poor, living in a
Hmm.
crappy neighborhood, living near a factory that
Right.
has toxic fumes,
Right. Right.
living in a zip code where the police tend to use high levels of violence,
Mm.
or where they do you know what stop and frisk is?
I don't think I've heard of Sovereign.
Which is where police are given permission to stop a person without due cause and and see if they're carrying weapons.
Oh my gosh.
Yeah. Now
Wow.
this was long before George Floyd,
Right, right.
but it culminated in George Floyd, didn't it?
It did. Yeah, that's incredible. You don't really know a person until you hear their story. And
Hmm,
after all those years of preparing to be something that you want to be, what's the point of just hearing about their symptoms and
that's right.
diagnosing them a prescription when you don't know their story? And that story could
Right.
be, like you said, the story of a life.
Yes, yes. And there are reasons that this came to pass.
Mm-hmm.
The biggest one is that medicine became a marketplace. In medicine, when the corporations got control,
Mm-hmm.
um, um, the persons who determine health policy
Mm-hmm.
are not only the economists and the physicians and the policymakers.
Right.
The persons who set policy are the shareholders
Ah,
for the
okay.
insurance companies,
Ooh,
for the pharmaceutical industry.
interesting.
Because if the share, you know how shareholders get their
Yeah.
dividends,
Yeah, yeah.
and the dividends usually come once a quarter,
Mm-hmm.
and the shareholders go berserk if their dividends fall.
Right, right,
So the insurance company, Aetna, United Healthcare,
right, right.
those guys are deciding what to do based on keeping their shareholders happy.
Ah,
See?
that's
So
terrible.
but it has little to do with what people who are sick need
Right.
or even what doctors wish they could do.
Wow, that's such a unique perspective to look at things, really.
Yeah.
Yeah, because now we're losing sight of, again, who the patient really is.
Yes.
It's become very corporate, and I need to
Yes.
get this done. I have an appointment time. I'm coming in and I'm going out.
That's right.
That's how it's become.
I was at a medical conference. It was in Florida.
Oh, wow.
It was the American College of Physicians, which is a big, big organization for people who are internists, internal medicine.
Ah, okay.
And I saw, and they have these booths, the exhibit hall, they have all these booths.
Mm-hmm.
And I went to a booth that said they were um, developing, or they were trying to sell
Mm-hmm.
AI systems that would record and immediately put into text
Mm-hmm.
what happened in the interview. So
Oh,
it was like the AI scribe. They're all over the place,
oh, wow.
where the AI apparatus
Uh-huh.
um, uh, records what the patient says and the doctor says. They record the whole thing. They
Uh-huh.
boil it down into kind of a summary, and that summary takes the place of what the doctor herself should be writing.
Yeah, it's so
See?
scary to think about how AI can replace a person's
That's
job.
right. That's right. And um, at the beginning, they said, well, this is for you to edit. This is what the machine thinks
Mm.
was said. But you, doctor, have to go look at it and edit and correct it if it gets things wrong or if it forgot.
Oh my gosh.
Well, you can imagine how many physicians will say, oh, I'm sure it's fine.
Yeah. Yeah.
Why? Because this is expected to save time.
Right.
And instead of the patient getting 15 minutes of
Hmm.
my attention,
Hmm.
they'll get 13 and a half minutes of my attention, which means that maybe over the course of a day, I can see one more patient per day.
Mm.
Thereby doing what? They do that so that I can see one more patient per day,
Right.
so that the insurance company gets paid.
They get paid more.
Why? See?
Oh, wow. Wow. I never thought of it that way. Do you think that this AI could also be beneficial in the healthcare industry?
There are some ways it could be, but I learned something very critical from the exhibit hall
Hmm.
this at this meeting. When I asked the woman who was trying to sell me this system,
Yeah.
uh, how does the AI decide what to include and what not to include?
Right.
Oh, well, we know what your problem list is, which means the list of diseases that the patient allegedly has. We know your problem list, so we will only give you the data that's necessary to address your problem list. And I said, well, what happens if they talk about something that's not on the problem list? Oh, we edit it out. We don't bother you with all of that. chit chat.
Mm,
I said, no, no, no. Doctors need what you're calling chit chat.
right.
Doctors need to understand what it is their patient's going through.
Of course. Of
If
course.
it's, they think they're gonna evict me from my apartment, I need to know that.
Of course. Yeah, absolutely.
If my granddaughter just had the baby and it's got Down syndrome, I need to know that.
100%.
And it's treated as chit chat because it's not on the problem list.
Yeah, I don't
So,
think we're at the level to call AI, we can't depend on AI yet. We can't.
no,
And like you said, these companies that are advertising these AI systems for the benefit of themselves and themselves only,
yeah,
only in it for the money. And
it's,
what they called so-called chit chat is what is fundamental and has
yes.
been working for generations. Okay, I think we'll just dive right into my next question.
Okay, please.
So when you first proposed the idea of narrative medicine,
Mm.
what kinds of reactions did you receive from colleagues, friends, mentees, students?
Well, it was uphill because I gathered together some people from the university, some literary people, philosophers, creative writers,
Wow.
poets, and some of the doctors at the medical school and nurses and social workers who agreed with me about
Wow.
the need for
Yeah.
this level of uh, basic understanding about one's patients.
Mm.
And we were fortunate to get a lot of funding. We got funding first from the National Endowment for the Humanities, and then from the National Institutes of Health. And I ended
Wow.
up getting 10 years, more than 10 years of funding to do this work.
That's incredible.
And it was a time when these kinds of movements were happening elsewhere. So I was in
Hmm.
a group with another 8 or 10 other medical schools who were interested in the humanities, in social sciences,
Hmm.
anthropology, philosophy.
Right.
Um, and each of us at our different medical school developed curriculum.
Oh.
And to this day, the things that we developed, and this was in like 2006 or 8, um, the courses that we developed are existing today.
Wow.
And it includes courses about music and medicine,
Right.
playwriting and creative writing, and it includes the humanities and creative work. So
Wow.
this was stealth. I didn't know that it would last so
Yeah,
long.
I mean, not my dad always tells me knowledge is everlasting, and there's only so much that can be changed in
Yeah,
fundamentals of such a deep and in-depth
yeah,
topic like narrative medicine.
yeah, yeah. Well, and it itself, I mean, it started with like 8 people in a conference room.
Yeah,
And since then, I mean, our work at Columbia has grown enormously. We now have a master's degree. We have this certificate program, the one I said
wow.
that is all asynchronous. Um, we have many, many different all our graduates who have taken our training are
Mm.
now doing work in their own hospitals and
Oh,
doing
that's
research. And
incredible.
so the field is really growing intellectually, pedagogically, and research-wise.
Ah,
Uh, the other thing, I started another group called Narrative Medicine International because just because I know people tell me things,
yeah,
that there's work in Eastern Europe, in Western Europe, in UK, in Asia, and they're calling it narrative medicine. I said, well, let's call it
yeah.
what it is.
That's incredible. I mean,
So,
this subject is so widely accessible, right? I
yeah.
mean, essentially, For people unfamiliar with the term narrative medicine, how would you describe it in the simplest way possible?
It's caring for patients determined to understand who that patient is.
Mm, that's beautiful. So, why is storytelling such an important tool in medicine?
Well, it's one of many. Um, um, I hesitate because it's not only the storytelling.
Mm,
That's one piece of it.
right, right.
The story has to be heard. You know, in literary theory, we talk about close reading, where the reader gets very, very intimately involved with the text.
Hmm.
And a close reader will notice everything that that author is doing. You know, what kind of images
Right.
or metaphors, what kind
Yeah, like deeply analyzing. Yeah,
of deeply
that's what we do in school. We actually did that in school today.
good, good. And so it becomes a resonating connection between the reader and the writer or the narrator.
Yeah.
Um, but it makes me a little worried when I see, oh, we're having a story slam. Come tell us your stories about cancer. And that happens.
Right.
And I wonder if the person's telling the story are doing so for a particular reason.
Hmm.
Are they asking for
Money.
absolution? Are
Yeah.
they asking for money? Are they trying to get something off their chest?
Yeah, I think,
Are are
yeah,
they looking for advice?
right. You just never know. I think it's become so political and everything is so like you're so heavily involved with forces that you wouldn't have been involved with a decade ago.
Oh yeah,
Because
right,
of all these different factors, it's
right.
overwhelming. And a lot of people in our world don't have access to healthcare, which
No,
makes them so much more prone to asking for these things that you just
precisely. So when you see the moth is having a story slam about
mentioned.
healthcare,
Yeah,
and people go and they tell their stories to complete strangers who they'll never see again in their lives,
yeah.
what are they expecting in return? Or I should put it another way,
Hmm.
what are they owed in return? Oughtn't there be someone there who is listening as closely as a close reader reads, who might be able to say, I hear you three times going back to the question about food in your apartment, and you're worried that your kids are not having enough to eat. What can be done? Instead of just saying, yay, 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 next,
Yeah, yeah.
right? Right?
Definitely, yeah. Do you believe all health professionals should be trained in narrative medicine
Yes, absolutely.
because it is so widely accessible?
Yes. Although, as we have been saying, not everyone who thinks they're practicing narrative medicine actually does so.
Mm,
It's become kind of popularized.
yeah,
So they think a story slam is narrative medicine,
I guess
and
so.
it's not. And it creates a kind of, well, anything that gets hyper popularized is going to have, you didn't get the whole picture there.
Right, right.
And that's kind of where we are, which is better than if nobody was.
Better than no awareness, right?
That's right. Um, but now there's a fair amount of here, come work with us so you can see how it works if you're doing it, with these kinds of skills.
Right.
So I mean, this is just the beginning kind of.
Definitely, yeah.
I mean, the first books came out 2006, 2008.
Hmm.
And that's not that long ago.
No, not at all.
And there's a whole now international um, um, research effort.
Wow.
And we have the capacity and the time that has gone by to say, well, what happens as a result of these?
Yeah.
Do these medical students become different kinds of doctors?
Right.
Do
Yeah.
they remember any of this 3 weeks later?
Exactly.
Does it
Exactly.
change what they do for a patient in the hospital?
Definitely, especially with the use of artificial intelligence increasing. We don't know what's next. I mean, in an age dominated by technology, electronic health records, shorter appointments, how do you think doctors can still make space for patients' stories?
Well, they have to be paid more for one thing.
Mm,
They have to be given more than 12 or 13 minutes. And they have to develop skills that they might not have.
mm,
Not all of them are as fortunate as I to come in as a very devoted and quite skilled reader.
right. Definitely.
And, you know, tuning yourself, attuning yourself
Mm,
to a patient's conversation instead of interrupting and saying, oh, you can talk to the social worker about that.
yeah.
Get that x-ray that I ordered. Now, it's not the doctor's fault. The doctor's being paid to do a certain
Job.
task. So our struggle, like we were talking 20 minutes ago,
Mm-hmm.
our struggle is much more with the funding
Mm-hmm.
priorities and who's in charge of what it is that physicians and nurses are expected to do.
Definitely. I mean, you get paid for what you do, and as much as doctors are presumably passionate about what they do, at the end of the day, they're just human beings, and they
No.
should be treated and fairly represented for what they do.
Meanwhile, the ways that persons seek healthcare
Hmm.
have changed a whole lot.
That is true.
I was just on another call with a student, medical student, who worked for a year in a pediatric clinic. Um, but it wasn't like a regular medical practice.
Hmm.
People came and went. They didn't see the same doctor every time. It was like a walk-in, like
Yeah, yeah,
urgent care or something.
yeah.
And that's not pediatric practice,
No,
where you've seen this
a
child.
regular patient every time.
Oh. And it's just easier for people. Oh, I'll pop into the Apple Clinic because it's near my work.
Yeah.
Oh, I'm on vacation. I could go to the Apple Clinic in East Hampton. Oh, so it's more like transactional.
I agree with that because nowadays I don't think we can even blame the customers or the
No,
patients because
no.
it's getting harder and harder to schedule appointments with your doctor. Like for example, the other day my brother he got hurt. So it was kind of like a long-term injury kind of and we decided to just go to urgent care instead of our regular pediatrician that has been seeing us since the time we were babies. And in a sense, they know more about us
Yes,
than a healthcare professional at urgent care would.
yes, yes, of course.
Yeah, because of again the ideas and implementation of narrative medicine
Yes,
since childhood.
right. But um, it is a shocking problem
Hmm.
that any time a patient wants to make an appointment with any kind of doctor, they're told, oh, well, he has an opening in 6 months.
Exactly, exactly. Oh my gosh,
So
exactly.
what are you going to do with
What are
that?
you gonna do? You can't do anything. I don't want to see you in 6 months. I need to see you now.
And the only way to do that is to pay a whole lot of money
Mm,
and subscribe to what they call boutique practice,
yeah.
where you pay $3,000 up front just in case you need to see your doctor.
I guess so. And
See?
that's how the world's becoming.
So that's where we are. We're not being singled out. I'm sure if you ask somebody who runs a restaurant, well, even though I have empty tables, I tell open table or Resi that I don't
Hmm.
have any space because who's going to come to a place if it's easy to get a reservation?
Right.
See?
Yeah.
I
Yeah,
guess it's not
definitely.
really in demand.
Definitely.
See?
I see what you're saying there. That's actually a really unique perspective. A lot of viewers may not have even thought of it that way.
You know that more and more doctors are quitting early, going to go get an MBA.
Yeah.
And that's because it's become not an easy life at all.
Definitely, 100%. I
So,
actually did an internship in Texas. My aunt is an oncologist, and she was on call for a week, and she was completely burnt out. She has two kids as well, and one of them's in high school, one of them's in middle school, and it's hard to see how a mother of two children working as an oncologist. I mean, oncology is a very specialized field as well, and in a sense, it's very like she sees patients go and come and go
yes,
and come,
yes,
and
yes.
it's stressful.
Hmm.
So, how do you think narrative medicine can help address issues like burnt out or moral injury and compassion
Yes,
and fatigue among healthcare workers?
yes, absolutely. And we go after those things. And there are ways to help individual practitioners express what they're going through.
Mm-hmm.
And that, of course, is the beginning of,
Yeah,
I mean, they'll say, well, I never really put it that way, but you're absolutely right that I've been used. And
definitely.
I feel like an old car that's being, you know,
Constantly rid.
right?
Yeah,
So that's the first part is to help people really come to terms with what it is that and it turns out it's not so much depression as it is rage,
that's true.
you know?
That's true.
And so many of these physicians are being treated for what they call burnout. Well, it's not exactly exhaustion. It's rage. What
Mm,
happened to this life I thought I would be leading?
right.
And what does that need? That needs unity.
That's
That needs
that's
another
amazing. Oh, that's
another movement.
beautiful. That's beautiful the way you said
Yeah.
that. Moving on to a completely different topic, Colombia has a unique program in narrative medicine. How do you see it evolving in the next decade or so?
We keep learning more and more about
Yeah.
what matters to individual patients, what matters to individual health systems. We're part of a big hospital system, many affiliated hospitals, and we have a pretty good sense of who's happy and who's not. And I think, I think one of the answers to the many questions you've that we've talked about
Mm-hmm.
is whether those in charge, those who make decisions, are aware of as we say, sequelae, the consequences of
Mm,
those decisions.
right.
Um, you know, it's not enough to say, oh, we'll give you some yoga treatments or it's yoga classes, and that will help your spirits,
Right.
or things like that. Or here, we're going to have an ice cream social and everybody's going to get free ice. No, no.
No.
We have to look at what it is that we're being prevented from doing.
Right.
What happened to the reward? that is supposed to come from the care of patients.
It's true.
And these are systems problems. They're certainly personnel, you
Hmm.
know, if you don't have as many doctors as you did 5 years ago, well, what do you think? So when you say what is the future for narrative medicine, I
Uh-huh.
think I think we're becoming all the more savvy about what it is that makes the care to patients deteriorate, as well as what makes the life of the physician deteriorate. Um,
Interesting.
and from there we try making some changes and we
Right,
research
right.
what those changes do. And if we're able to teach medical students, for example, to pay attention to what their patients say, is that going to make a difference?
Yeah, definitely. Yeah.
So we do that, and then we do the research to show, what difference does it make?
Yeah, that actually brings me to my next question. What advice would you give to medical students who want to integrate the humanities into their practice in the future?
Well, first of all, they have to choose well because not all medical schools have ways to um, include the humanities and the arts.
Right.
Some do, some don't. So you have to be aware as you're looking at schools, which ones you want to end up in. Um, and even in schools who don't have, I'm the chair of a medical humanities and ethics department. It's a whole
Mhm.
department at my medical school. Um, what if your medical school doesn't have a department like that? There are plenty of
Mhm.
things you can do.
Right.
You have to hunt around a little bit. There may be a medical school in your city that does, and so you go there, or you go to some events.
Right. So be open
Uh,
to exploring new
yeah,
places.
there are conferences that you go to. Even you can even get webinars. Some of them are free.
Yeah.
We have narrative medicine rounds, free once a month. These
Yeah.
lectures, no, it's great. Um, we mostly choose writers, artists, some scientists, not
Yeah.
not often medical people, although sometimes.
Mm.
Um, and it's just an hour, and they read from their latest book of poems or stories, and a moderator has a like Q&A and conversation, and it's a way to just get zoned in to some of these things that can matter
Yeah.
for improving your medicine. So if you go to our website, you find this narrative medicine rounds, and we have different ways. We have once a week, we have what we call virtual group sessions, which is come do narrative medicine with a Columbia person. It's an hour once a week.
Wow.
Anybody can come.
Oh, wow. Oh my goodness, that
Yeah,
sounds exciting.
yeah, yeah. Virtual group sessions, and it's all, I mean, it's all under the education and the programs on our website. But that's easy. The harder parts are getting the funding to do this more long-term research,
Hmm.
to get evidence that including training in close reading or philosophy or visual art will improve the healthcare that a doctor's able to give.
Right.
See?
Definitely. Yeah.
And there are lots. I mean, there's a lot more than there was 10 years ago
Definitely.
of that kind of work.
I agree. Yeah.
But it's gotta,
Yeah.
it's gotta, it's gotta boil up
Hmm.
to the actual corporate fixers.
Yeah. I mean, we're capable of so much more, especially in
Precisely.
this generation. I mean, with the
Yeah.
technologies that
Well,
we
we hope
have in our
so.
hands.
Yeah. We hope so. So the
Yeah.
answer to your question is more targeted, sharper, toward, in a funny way, proving
Mm.
that some of the things we believe very deeply can actually be demonstrated.
That's beautiful. That's a beautiful answer. Looking back on your career, what are you most proud of?
Um, I often say that having a life in literature and a life in medicine doubles my work. I have to write articles for the clinical literature. I
Yeah.
have to write articles for the Henry James Review and Poetics Today. And so when I counsel people who are interested in doing this kind of thing, I say, you know that you will work twice as hard
Mm,
as people who just have one life.
that's amazing.
But the dividend is you get to live twice as long.
That's amazing. Yeah, I mean, it's so fulfilling, right? I mean,
Yeah,
like when you complete something, like I know I have a few friends in medical school right now, and I often ask them the journey from high school to medical school. They say it's difficult. It's difficult, but it's rewarding at the
yeah,
end. You
yeah.
feel satisfaction, like, okay, I've done something worthwhile and
Mm,
something that's important to me in my life. I'm helping people. I'm essentially saving lives, and it's very cliche, but that's really what it is.
yeah,
That's the depth of medicine,
yeah.
really. What advice would you give to young people, whether future doctors, writers?
Do what you and you alone can do.
We are down to our rapid fire 10 questions. You can answer these questions as fast as you can. So if you could describe narrative medicine in just 3 words, what would they be?
Listen, listen, listen.
What was the very first story or book or patients that made you realize stories matter in medicine?
Too many to count.
If medical students only read one novel during training, which one should it be?
The Wings of the Dove by Henry James.
Who inspires you more, writers or doctors?
Writers.
What's your favorite place to read when you're not at Columbia?
I have a chair in my living room that looks west toward the Hudson. That's where
Oh,
I sit and read.
very cool. If narrative medicine had a theme song, what would it sound like?
It would sound like a partita by Bach.
Interesting. So very classical, old school. Okay, okay, interesting. What is one thing your students do that always makes you smile?
Oh, right.
Mm.
They say, Dr. Sharon, I wrote something. You know, yeah. Let
Nice.
me see. Let me see.
If you were a doctor or a scholar, what other career would you have chosen?
Novelist.
Lastly, what is one story from your own life that you think shaped the way you teach today?
My freshman English teacher.
Wow. In high school or in college?
No, in college.
Oh, okay, in college.
Yes. Um, he was a young professor just out of Brown with his PhD, and he so understood the power of Shakespeare, the power of these more modern poets,
Mm-hmm.
and he galvanized. He died some years ago of a bad renal cancer,
Oh.
but he we were staunch friends for decades, decades,
Oh,
decades.
wow. All right. Thank you so much, Dr. Sharon, for your time today. It's been such an honor speaking with you. Columbia is actually my dream school, and I
Okay,
hope that
well,
I can go there someday. I mean, it's just been
yes,
so inspiring talking to you, speaking about Columbia.
you will end up where you choose,
Yeah.
is my prediction.
Thank you. Thank you so much, Dr. Sharon.
Ooh, pleasure
Bye-bye.
talking with you.
Thank you so much.